Hello everyone, my name is Moueden Amine. I am Associate Professor in Medical School of Oran in Algeria. Today I am going to talk about understanding autoimmune hemolytic anemia, pathophysiology and classification. We start with the introduction. Autoimmune hemolytic anemia is acute extracorpuscular hemolysis caused by autoantibodies directed against red blood cells. These autoantibodies are present on red blood cells and or in plasma, and they are often directed against a high incidence antigens. The autoimmune hemolytic anemia is not rare, and 2/3 of disease is seen in women. Classification. The basic classification subdivides autoimmune hemolytic anemia in primary idiopathic and secondary, with the latter being associated with a number of underlying infectious, neoplastic and autoimmune disorders. Acute autoimmune hemolytic anemia are generally post-infectious, most often viral. Chronic autoimmune hemolytic anemia are often observed following autoimmune pathologies as malignant lymphoid proliferation. Classification according to the thermal range of antibody recognizes 3 types of antibodies. Warm antibody type. The autoantibodies in warm autoimmune hemolytic anemia have temperature optimum at 37 degrees Celsius, and they are of the immunoglobulin G class in most cases. Immunoglobulin E autoantibodies occur in 15 to 20% of the patients. 2. Cold antibody type observed in cold agglutinin disease. The autoantibodies in cold autoimmune hemolytic anemia have temperature optimum of 3 to 4 degrees Celsius, and more than 90% of pathogenic cold agglutinin are of the immunoglobulin M class. Paroxysmal cold hemoglobinuria. And finally, mixed warm and cold antibody autoimmune hemolytic anemia is very rare. Pathogenesis. Autoimmunity mechanism. Several mechanisms are involved in autoimmune hemolytic anemia. We can cite similarities in structures between some antigen of the erythrocyte membrane and other antigens introduced into the body would lead to a cross-immune response, like Mycoplasma pneumonia and antigen E. Dysregulation of the immune system. Deficit in regulatory lymphocytes alpha-methyl dopa can block suppressor T cells and thus cause autoimmune hemolytic anemia. Activation of autoreactive cells, tolerance rupture of autoreactive T lymphocytes against red cell autoantigens. Family forms some class 2 of major histocompatibility complex, HLA-DQB1 and HLA-DRB1. Mechanism of hemolysis. The mechanism of hemolysis depends on the type of antibody. We can see IgG-dependent erythrophagocytosis, complement-dependent erythrophagocytosis, and complete intravascular hemolysis. Here the antibody can activate completely the classic pathway of complement. Discovery. We can see the autoimmune hemolytic anemia after infectious episode, trauma, surgery, pregnancy, chemotherapy, or radiotherapy. And we can see the autoimmune hemolytic anemia after accidental discovery, like difficulty in erythrocyte grouping, autoagglutination in the sample tip. Clinical signs are dominated by the classic triad: anemic syndrome, jaundice, splenomegaly associated or not with hepatomegaly. Diagnosis: usually this is diagnosed using a combination of clinical and laboratory findings of hemolysis using the direct antiglobulin test or Coombs test. Complete blood cell find normal or microcyte anemia. Reticulocytes count is often increased, but we can see reticulocytopenia in some cases, like infection by parvovirus B19 or lymphoproliferative syndrome. Blood smear find polychromasia, spherocytes, erythroblastosis, or agglutination. Signs of hemolysis: raised unconjugated bilirubin, reduced haptoglobin, increased lactate dehydrogenase. Direct antiglobulin test. This agglutination technique. The direct antiglobulin test with polyspecific or anti-AGG and anti-complement demonstrates that immunoglobulin G and or complement, usually C3d, is bound to the red cell membrane. In this figure we can see how to make the direct antiglobulin test. The first antiglobulin serum, polyvalent human antiglobulin, is added to wash the red blood cells from the patient, and agglutination indicates the presence of immunoglobulin or complement bound to red blood cells. Results: direct antiglobulin test positive for AGG only or AGG and complement indicates the presence of the warm antibody. Direct antiglobulin test positive for C3d complement only indicates the presence of the cold antibody. Direct antiglobulin test positive for AGG and C3d indicates the presence of the mixed forms, but here we have a high concentration of cold agglutinins. Remark: direct antiglobulin test negative cases can be seen in 5%, like the presence of AGE or low affinity autoantibodies. Immunoglobulin G, which generally react at 37 degrees Celsius, are usually directed against epitope of the rhesus system. AGM autoantibodies are often directed against the E system. Autoantibody specificity in paroxysmal cold hemoglobinuria is usually anti-P. Second technique, serum testing, combining a patient's serum with a panel of red blood cells of known phenotype according to the results of the direct Coombs test. The reaction is done by an indirect antiglobulin test. Elution should be performed to elute of the antibody and determine its specificity with a panel of reagent red blood cells of known phenotype. The first step is an elution is to wash the red blood cells to remove any unbound immunoglobulins. Following this, dissociation of a bound antibody can be accomplished by a variety of elution techniques. Temperature at 56 degrees Celsius, pH, and organic solvents like ether. Conclusion: A better knowledge of the pathophysiology allows to adapt to the appropriate therapeutic protocol. First-line therapy consists of long course of steroids administration. In refractory old autoimmune hemolytic anemia patients, the rituximab is the first choice. The splenectomy can be still considered a good therapeutic option in patients older than 60 years old, when rituximab administration cannot be performed. And thank you for your attention.